proceed with the examination. अच्छा, और कुछ important है history में? What are the other drugs which the patient can be on, Jasmine? ठीक है, drug history is a part of the history only, the drugs which the patient might be on, na? So what drugs do you expect a patient with a intracranial lesion to be on?
Ma'am, the patient is currently on electroxin. Ma'am, the patient can be on any analgesics for headache.
Okay, what else? ब्रेन ट्यूमर है ना, पेशेंट का रेज्ड आईसीपी अगर होगा या कुछ होगा तो क्या क्या ड्रग्स पे होते हैं ऐसे पेशेंट्स?
Ma'am, they can be on dexamethasone, ma'am.
और
And then
गौतम?
Hello, ma'am. Patient might be on, as she said, analgesic for headache, and she might be on diuretics to decrease the ICP like acetazolamide, those kind of drugs. She can also be on anti-epileptics to prophylactically to avoid seizure episodes. And if there was any hormonal imbalance like this patient where hypothyroid patient might be on that hormonal replacement therapy also.
Supplementation. So what is
Yes,
the anesthetic relevance of knowing the drugs? How do you think these drugs are important for the anesthetist?
Ma'am, the most prominent will be the anti-epileptics, ma'am. The most commonly used are phenytoin, which is actually an enzyme inducer. So if the patient has been taking chronically, we should expect a short action of our muscle relaxants. And if
Drugs
the
also induction agents as well.
yes,
ठीक है?
ma'am, yes, ma'am,
Requirements,
yes,
dosage requirements, and this thing frequency of dosing will increase.
increase, ma'am.
हाँ.
And since he is already an anti-epileptics, induction also will be going towards where the agents which are better in anti-epilepsy, like we'll be preferring
Okay.
thiopentone more
ठीक
than
है. So
propofol.
intraoperative anti-epileptic doses have to be maintained. The levels have to be
Yes, ma'am.
maintained of these drugs. So these dosing
Yes,
should
ma'am.
be adequate.
Repeated. Yes, ma'am.
Okay. Continued in the perioperative period.
Yes, ma'am.
Okay. What else? Any other implication of anti-epileptic drugs? Any other side effects? देखो, this is for all of you. Whenever you are doing any case, you have to do the pharmacology of that case. Okay? ठीक है? Because like anti-epileptics, they can have idiosyncratic reactions and they can affect the liver function. They can lead to thrombocytopenia, anemia. ठीक है? Megaloblastic anemia हो जाता है, नहीं तो bone marrow suppression. These are known side effects of these drugs. ठीक है?
Okay.
So you have to look at the counts. ठीक है? Cause can also be a offending agent, could be one of these drugs as well. If the patient is anemic or having thrombocytopenia, then these become relevant to the anesthesiologist. ठीक है?
Okay. Okay.
हाँ. और बताओ next drug.
Ma'am, next as I said, she could be on diuretics in order to reduce the ICP, so we
Okay,
should be
very
very
good.
much careful about the serum nitrates, like
Very good. So
patient
you will
electrolytes
order
might be
serum
reduced
electrolytes on the morning
on the
of
day of. Yes,
very
ma'am.
good. Next.
A hormonal assay should be done prior so that
ये
our
तो
importance.
investigations में आ गए बेटा. I'm not talking about investigations. Drug. Any other drug? Steroid बताए थे उसने. Steroid
Yes,
का
ma'am.
कोई relevance?
Ma'am,
A patient who has been on steroid for 3-4
for
months, what do you think is the concerns? What could be the
patient might have suppressed hypothalamic adrenal axis, ma'am. So we might have to supplement with steroid
Might have,
perioperatively.
we have to supplement.
We have
Okay.
yes, we have to supplement with steroids perioperatively, ma'am.
Or that's it.
Immunosuppression will also be there for the patient since she's on chronic steroid.
Next.
I'm not so sure about this one.
नहीं, you try. कुछ chronic steroids के कुछ
steroid side effects are yes, ma'am. Chronic side effects of steroids will be
good.
Most will be osteoporosis will be there. Patient might have Cushing's syndrome features might be present if she has been on chronic and if the dosage is increased.
Cushingoid facies.
Yes, ma'am. So for
That
us,
difficult mask ventilation.
Yes,
have
ma'am.
you ever been posted to neurobase OT? All the patients are like this thing, football
Yes,
face.
ma'am.
ठीक है? Mask ventilation can be
Ventilation will be
difficult. ठीक है? In such
yes,
facies.
ma'am. Yes,
ठीक है,
ma'am.
they can be anticipated difficult airway patients. ठीक है, neck
Yes.
becomes short, there's a buffalo hump.
Yes,
ठीक है,
ma'am.
so airway difficulty can increase. Plus, what happens to the vasculature?
They are usually easy bruisal, ma'am.
The bruisability, thin and
Yes,
fragile veins. So
thin
it
and
is
fragile.
difficult
Yes,
to
ma'am.
secure an adequate
An
IV
IV cannula.
access to these patients.
Yes, ma'am.
ठीक है? So
Yes,
these
ma'am.
are all the concerns. So for every case, please do the pharmacology because drugs and their associated concerns are a part of the preoperative evaluation. ठीक है? Now
Okay.
go on to
Okay.
examination. Examination, who is
Patient,
presenting?
ma'am, Varsha.
Varsha, where are you?
Yes, ma'am.
Bolo.
Patient was examined while sitting comfortably in no visible distress.
Varsha, where
On
is the camera?
patient was moderately built and nourished, conscious and oriented. Weight 60 kgs, height 162 centimeter, BMI 22.9 kg per meter square. Radial pulse 76 beats per minute, normal in rate, rhythm, volume, character. All peripheral pulses palpable, no radioradial, radiofemoral delay. Blood pressure 124 by 80 mm of Hg, right arm sitting position. Respiratory rate 18 per minute, abdominothoracic. Axillary temperature 98.6 degree Fahrenheit, JVP 3 centimeter, not elevated. Head to toe examination, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Hair texture normal. Prominent supraorbital ridges, enlarged lower jaw, increased spacing between the teeth in upper and lower jaw, no loose tooth, no artificial dentures, thyroid grossly normal, thickening of fingers in hands and feet, good venous access visible on the dorsum of both hands. Patient had no Cushingoid features, no features suggestive of hypothyroidism. Airway examination, mouth opening.
Wait. Varsha, examination pe no feature suggestive of hypothyroidism. What does that mean?
Ma'am, patient did not have any puffy face, any loss of eyebrows, and dry, cold skin or edema.
Okay. So, Adip, what can you expect in the in the vitals of the patient? What changes can you expect?
Ma'am, in the vitals, because we're expecting raised ICT, the patient may have a raised BP, and well, we could expect bradycardia, but then, as Varsha mentioned, it was at around 70.
So what is the reason of this trial? What is the mechanism? Why does this occur? These cardiovascular changes?
Ma'am, these cardiovascular changes occur to maintain cerebral blood flow. Because I mean the cranium is a rigid compartment and it has only space for the blood, CSF, or the brain tissue. So if either one increases in tension, the others will have to compensate for it.
Okay.
So because of the raised ICT, I would expect the vasculature to be compressed, which would lead to a reduction in blood flow to the brain. And as a compensation, the heart rate, the heart would have to increase perfusion to the brain by increasing BP.
Okay. What is cerebral perfusion pressure? How do you
Cerebral
define?
cerebral perfusion pressure is it's the it's mean arterial pressure minus the ICP. It's the pressure at which the vessels are perfusing the brain.
Okay. So as the ICP increases, to maintain the cerebral perfusion pressure, the MAP
Yes,
increases.
yes,
Okay, so this leads to reactionary hypertension. And why is there bradycardia?
ma'am, bradycardia so as a reflex to hypertension.
Okay, and what changes can you expect in respiration?
Ma'am, the Cushing's triad, this is leading towards the Cushing triad, where we could expect hypertension, bradycardia, and respiratory distress.
Okay, fine. ठीक है. Okay, continue with the examination, Varsha.
Airway examination, mouth opening more than 3 fingers. Calder test, lower incisors lie anterior to the upper incisors. Upper lip bite test, normal. Prognathism present, MMPG2, mildly enlarged tongue, thyromental distance 8.5 centimeters, sternomental distance 15 centimeter, Delilkins test normal, neck circumference 36 centimeter. CNS examination, patient was conscious.
Would you call this an anticipated difficult airway?
No, ma'am. Like patient in acromegaly, they can have difficult airway, but this patient did not have features.
What are the features? What are the airway changes in a patient with acromegaly?
Ma'am, patient has enlarged lower jaw, then maxillary bone is all can be enlarged, then increased spacing between the teeth, enlarged tongue, and if in severe cases even the glottis may be involved. Size of vocal cords can be enlarged. The space between the vocal cords can be reduced, and cartilages can be enlarged.
Cartilages can be calcified also. Okay. So actually the point is that although it is not an anticipated difficult airway because of the examination, but internally how the passages are and how big or small the glottic chink is, so that is not really predictable. So they are always considered as anticipated difficult airways. Okay? Although on examination findings, according to you, there was no obvious airway abnormality, right?
Yes.
Okay? Calcinosis of glottis, etc., can also occur. Fine.
Yes.
And you should always keep, because of the reduced chink of the glottis when you are preparing the airway, one size smaller size tubes must always be kept. Okay? Okay. Next.
CNS examination, patient was conscious, GCS 15 by 15, oriented to time, place, and person. Higher mental function, intelligence normal, memory normal, no emotional disturbances, speech normal, right-handed. Cranial nerves, cranial nerve 1, patient was able to smell coffee powder in both nostrils independently.
Cranial nerve examination, jaldi wo kar do. Any abnormality?
No, ma'am, no abnormality in cranial nerve.
Okay. Amir? Amir is there?
Hello, yes, ma'am.
Amir, I want you to tell the Glasgow Coma scale accurately.
Ma'am, basically, the Glasgow Coma scale has 3 components. The I component is classified
Amir,
as.
have you switched on your camera?
1 second, ma'am.
I want everybody to switch on. Especially if you're speaking.
Ma'am, then it has an I component. Ma'am, it's from 0, 1 to
eye opening. Batao.
Eye opening. Ma'am, it's if the score is 0, then the patient has no eye opening. Then, ma'am, 1 score indicates
0 kuch hota hai? Is there anything called 0?
Sorry, no, sorry, ma'am. It's ma'am 1.
Sorry, this is actually a very simple question, but this is just to put across to all of you. You know that if somebody by chance asks you GCS, that means a very basic question has been asked, and I don't want any of you to fumble in this. ठीक है?
Yes, ma'am.
Ma'am,
then a score of 1, the patient has no eye movement. And the score of 2, the patient has eye movement on stimulus
eye
to pain.
movement? Yeah, eye opening.
Eye opening on stimulus to pain. Then, ma'am, the score of 3 has the patient has eye opening on verbal command. And then, ma'am, a score of 4, and the patient has eye opening spontaneously. Ma'am, and then verbal response, ma'am.
It is called the best verbal response. Chalo, आगे बताओ.
Yes. From a score of 1, the patient has no verbal response, and then a score of 2, the patient the sounds are incomprehensible sounds. And then a score of 3, the score of 3, the patient has
Inappropriate words.
Inappropriate words. The score of 4. The patient.
Anybody who wants to continue from here? I think this is the toughest question for the day.
Hello.
Ma'am.
हाँ, कौन बोल रहा है?
Ma'am Sakshi.
हाँ, साक्षी बताओ.
Ma'am, for verbal response, when there is no verbal response, we give it a score of 1. When there is an inappropriate sound or speech, then we give it a score of 2. When there are inappropriate responses,
it is incomprehensible sounds. Incomprehensible sounds is 2,
or
and
speech.
appropriate words is 3. ठीक है?
Yes,
Incomprehensible, inappropriate साथ साथ नहीं आते हैं.
Yes, ma'am.
ठीक है? If it is absolutely incomprehensible, then it becomes 2. ठीक है? Inappropriate words is 3. आगे?
Ma'am, if the patient is confused but is able to answer the questions, then we give it a score of 4. And when the patient is oriented and giving appropriate responses, we give a score of 5.
Okay.
Ma'am, then moving on to the third component, the motor responses. Ma'am, when there are no motor responses, it's a score of 1. When there is an extensor response, ma'am, that is the decerebrate posture, we give it a score of 2. When there are abnormal flexion, that is the decorticate posture, it is a score of 3. Ma'am, when there is withdrawal on giving a painful stimulus, then that's a score of 4. And when there is purposeful movement to painful stimulus, then that's
Purposeful नहीं होता बेटा. That is called localization to pain.
of pain. Yes, ma'am. Localization of pain, then that's a score of 5. And then when the patient obeys command for movements, then that's a score of 6.
ठीक है. Back to Vandana. Thank you. हाँ, वंदना कंटिन्यू करें. सॉरी, वर्षा सॉरी. हाँ, वर्षा चलो.
Ma'am, should I say the rest of the CNS examination or?
हाँ, ठीक है. If there are any findings, otherwise just go fast.
No, ma'am, no finding in CNS examination.
Okay, next system.
CVS, normal shape of the precordium, apical impulse located in
any obvious findings?
No, ma'am.
Next.
Respiratory system and abdominal system also. No abnormality detected.
Dwara? What findings can you expect in the respiratory system of such a patient? Of a patient whose ICT would have been raised, or any such a patient?
In a patient of acromegaly coming from the nose, there might be enlarged nose and there might be macroglossia and there might
that
be
is airway related. Airway respiratory में कुछ हो सकता है? अगर suppose patient का raised ICT रहा है and somnolescent भी रहा है.
But in late stages of raised ICT, there can be bradypnea, a decreased respiratory rate can be seen.
Okay. ठीक है, and there can be basal atelectasis, microaspiration, pneumonias can be there. You must be very careful. ठीक है, if the patient is not very consciousness is deteriorated, must check for basal atelectasis and signs of aspiration.
Aspiration pneumonia, yes ma'am.
Okay, aspiration pneumonia, okay. And also there is an entity called neurogenic pulmonary edema. If the patient sometimes experience, in some patients, if there is a sudden rise in ICP, so that can lead to a reactionary pulmonary edema also. So this is just one term which I am just introducing to all of you. ठीक है, not really need to know the details. ठीक है, आगे. Any other points in examination, Varsha? Mic
No,
on? Okay.
No,
okay.
ma'am.
ठीक है, okay, fine. So can you give the diagnosis, Varsha, on the basis of history and examination?
Ma'am, on the basis of history and examination, the diagnosis in growth hormone secreting intracranial tumor.
बेटा जब भी हम diagnosis बोलते हैं ना, so always say 35-year-old female.
35-year-old female, known case of hypothyroidism, presented with chief complaint of headaches in 6 years and abnormal growth of body parts and secondary amenorrhea since 5 years, and was found to have acromegalic features on examination. Differential diagnosis is
हाँ बताओ.
differential diagnosis is growth hormone secreting intracranial tumor, query pituitary adenoma.
ठीक है. So this kind of a tumor, is it a microadenoma or a macroadenoma?
Ma'am, females more commonly have microadenoma. Hormonal secretings are more commonly microadenoma, and non-hormonal secreting tumors are macroadenoma, because they get diagnosed early if they are hormonal secreting.
और अगर नॉन हार्मोन secreting है तो क्या होंगे?
Ma'am,
and then what would be their presenting features?
Ma'am, their patient can have panhypopituitarism because of the enlarged tumor. It will compress on the normal pituitary tissue, and all pituitary hormones will be reduced. So patient will have signs, panhypopituitarism features, and there will be signs of ICT increased will be there.
Or most
and patient optic chiasmal compression. So patient will have visual field effects.
हाँ, ठीक है. So this patient had more of endocrine features suggestive of a microadenoma and less of compressive features, so not suggestive of a macroadenoma. ठीक है? ओके. अंजुषा से पूछ लिया हमने. ओके. अंकुश.
यस मैम.
बाकी सबने कैमरा ऑन नहीं किया है या मुझे फील्ड में दिख नहीं रहा सबका?
हम वो फील्ड में तभी आता है जब.
ठीक है. ओके अंकुश.
यस.
What are the investigations which you would like to order in this patient?
ठीक है मैम. सबसे पहले तो
justify each investigation. Okay.
Okay मैम.
This and the reason is this. चलो.
ठीक है. Ma'am, basic routine investigation में we will ask for a complete hemogram. Then we will ask for serum. If the patient is on any medication, so we can ask for serum electrolytes.
Hemogram क्यों चाहिए? मैंने बोला ना, every investigation you have to justify.
Okay ma'am. Ma'am, complete hemogram में we need hemoglobin because a patient may be anemic, is female patient with features of acromegaly भी है, and we will need a TLC count also, maybe having infections, any pneumonias, we are suspecting pneumonias
Anemia
also.
का cause क्या है इसमें?
Ma'am, female patients में तो we generally
अभी हमने कुछ डिस्कस किया था.
chronic disease भी है, chronic disease में anemia.
It could be drug induced. There could be drug induced anemia. ठीक है? And otherwise as a baseline this thing, not necessarily to diagnose anemia. As a baseline investigation, because the surgery you are expecting, it's a prolonged surgery and some blood loss is expected. So you do need a baseline hemogram and a coagulation profile.
Coagulation profile.
And a platelet count.
Platelet count and leukocyte count.
Next investigation.
Ma'am, we will ask for a serum electrolyte if the patient is on any diuretic therapy. So morning of surgery, serum electrolytes we need. CBC coagulation. And ma'am, a baseline LFT and KFT.
Okay.
Because patient is going for a major surgery.
Okay.
Then ma'am, we will also like to know the TSH levels. Thyroid patient is on altroxin for 6 years. So thyroid profile. And ma'am, a chest X-ray and an ECG.
कहाँ देख रहा है नीचे?
Ma'am, notes बना रहा हूँ.
अच्छा ठीक है, बताओ.
Ma'am, और ECG and X-ray for a 35-year-old female.
सिर्फ हमें सिर्फ थायराइड हार्मोन चाहिए. हमें और कोई हार्मोनल प्रोफाइल नहीं चाहिए. अंकुश.
मैम, हाँ, ग्रोथ हार्मोन.
ये ग्रोथ हार्मोन सिक्रीटिंग ट्यूमर है, तो यू आर हैप्पी विद थायराइड हार्मोन?
नहीं मैम, वी विल आस्क फॉर ग्रोथ हार्मोन का भी लेवल्स वी कैन चेक. आई एम नॉट श्योर इफ वी हैव इट हियर, क्योंकि मैंने कभी देखा
नहीं. वी हैव इट हियर नहीं, हम तो क्या करते हैं?
यस मैम. हम थायराइड प्रोफाइल एंड बेसिक रूटीन इन्वेस्टिगेशन.
क्या क्या होता है अंकुश?
मैम, T3, T4 एंड TSH.
ऐसे मत बोलो बच्चे, थायराइड प्रोफाइल मत बोलो. इट्स अ वेरी नॉन टेक्निकल टर्म. से T3, T4, TSH और से थायराइड फंक्शन टेस्ट. ठीक है, आगे.
थायराइड फंक्शन टेस्ट.
और
मैम, वी विल आस्क फॉर, वी कैन आल्सो आस्क फॉर एक्सरे ऑफ द नेक टू डिटरमिन इफ द सॉफ्ट टिश्यू.
हार्मोन हो गए, सिर्फ ये थायराइड हार्मोन्स और ग्रोथ हार्मोन, दैट्स इट.
मैम, सीरम बाकी वी आर सस्पेक्टिंग एक्रोमेगाली
होते हैं पिट्यूटरी से.
मैम प्रोलैक्टिनोमास कॉमन होते हैं, we can ask for prolactin, but अभी इसमें तो we are suspecting.
But you have to biochemically get all the hormone assays done. Levels of all hormones have to be checked. ठीक है, they could be coexistent anomalies, है ना? And ठीक है, so all these have to be.
Amenorrhea भी है.
क्या कराओगे अब बताओ?
ठीक है मैम, patient also has amenorrhea, so we can ask for prolactin levels and serum cortisol,
FSH,
FSH and LH. Yes ma'am.
है ना?
Yes ma'am. Then after blood investigations, we can ask for a baseline ECG. And
okay, what changes are you expecting in ECG in such a patient? What changes can you expect?
In acromegaly.
Acromegaly, raised ICT in such a patient where all this can be there.
मैम ब्रैडिकार्डिया हम
पेशेंट तो नहीं बोलेगा ना आपको मुझे रेज्ड आईसीटी, आप ढूंढोगे हिस्ट्री एग्जामिनेशन और इन्वेस्टिगेशंस में.
यस मैम.
तो पेशेंट तो अपने आप लेबल लगा के नहीं आएगा.
यस मैम. So in ECG we will be expecting.
What are the features of raised ICT and what are the features of acromegaly?
I'm not sure ma'am. Acromegaly का
चलो ठीक है, we go to the next person. Arushi, ECG findings relevant to this case.
Ma'am, in case of raised ICT,
Arushi कैमरा ऑन कर लो. हाँ
ma'am on है.
हाँ बताओ.
Ma'am, in case of raised ICT, we expect bradycardia. And in case of acromegaly, we expect
bradycardia के अलावा आरुषि raised ICT में और कुछ हो सकता है? arrhythmias भी हो सकते हैं, ठीक है?
Yes.
It is not necessary that there will only be bradycardia. You can even have rhythm disturbances otherwise. And
ma'am, in case of acromegaly, we
or ICT में or raised ICT में you can have cerebral T waves. There can be giant T wave inversions. ठीक है? So whenever you are doing these studying any case and doing the investigations, you should know. ठीक है कि तुम्हारी पैथोलॉजी में ढूंढा करो कि ECG में क्या होगा, इसमें क्या होगा, इसमें क्या होगा, है ना? So you should know. ठीक है? This is because when you are getting a case done, you should know what to look at what time. ठीक है? So there can be cerebral T waves. Cerebral T waves are nothing but giant T wave inversions which can occur with patients of raised ICT. ठीक है? और acromegaly में?
Ma'am, left ventricular hypertrophy is seen in acromegaly. So the changes of left ventricular hypertrophy can be seen, and ST depression and T wave inversions can be seen. Left ventricular strain pattern.
ठीक है. LAD भी होगा साथ में फिर left axis deviation, left ventricular hypertrophy और ST
strain.
और क्या बोला तुमने? Left ventricular strain. Why is there left ventricular strain?
Ma'am, because of hypertension, chronic, those acromegaly patients have chronic hypertension that changes due to that.
That's it. That causes left ventricular strain.
Ma'am, there is myocardial fibrosis as well.
That causes left ventricular strain. You said left ventricular strain, no?
Yes.
What do you mean by left ventricular strain?
Ma'am, left ventricular strain pattern is seen in the ECG. ST depressions and T wave inversions.
Basically, that is
ischemic changes.
हाँ, left ventricular ischemia. तो ischemia क्यों होगा, आरुषि? What is the reason of myocardial ischemia?
Myocardial, not sure.
Vandana, what is the reason of?
Restriction in cardiac, it's mainly due to oxygen demand and supply will be difference. In case of acromegaly, ma'am, there will be hypertrophy, which results in bulk of the left ventricle more, and blood supply will be decreased due to fibrosis and
understood, Arushi? ठीक है. So there is a demand supply. Whenever we are talking of ischemia or strain, there is a demand supply imbalance. Demand is increasing because of LVH and supply is decreasing because the coronaries and even the microvasculature. ठीक है? Just give me a moment. Hello? Beta, I am taking a class. Bye. Sorry. Yeah. So there is a demand supply imbalance and the supply will be decreased. Oxygen supply is decreased because your coronaries are affected, vessels are affected. There is atherosclerosis, calcinosis and fibrosis of the vessels. ठीक है? Even there is microvascular this thing calcinosis can occur. ठीक है, so this imbalance leads to left ventricular strain pattern. Okay, Arushi?
Yes, ma'am.
Understood? हाँ,
Yes,
okay. और जो हमने ब्रैडीकार्डिया अरिथमियास वगैरह बोले थे वो तो होंगे ही, और एसटी एलिवेशन हो सकता है?
मैम ischemic changes की वजह से ST elevation
Okay, ST elevation can also be there because of raised ICP. ठीक है, as independent as a feature of raised ICP and also in cases of subarachnoid hemorrhage. ठीक है, so in a patient with a cerebral lesion, ECG changes you have to find out whether they are because of a cardiac cause or are they because of a cerebral cause. ठीक है, you must be able to distinguish. ठीक है, it can be because of both. Okay, next investigation, Arushi.
Ma'am, we will need a chest X-ray.
Any other cardiac investigation? Chest X-ray कराएंगे. Okay.
Ma'am, to differentiate if it's a cardiac cause or a neurogenic cause, we can have stress testing.
Stress testing से बेटा पहले भी कुछ होता है ना, normal resting echo कराओगे?
Yes, ma'am.
Resting echo किस लिए?
Ma'am, to see the ejection fraction and any regional wall motion abnormalities if they are present in case of a primary cardiac disease.
देखो, जब भी हम echo बोलते हैं ना, first we always talk in terms of the structure and then we talk in terms of the function. आप ना एक echo report देखना, ठीक है? So always we first the sizes of various chambers, left ventricular hypertrophy तो नहीं है ना? All that, ठीक है? We always first say the structure, ठीक है? And in this, as far as structure is important, is there any left ventricular hypertrophy? ठीक है? And secondly, very important thing in a case of neurosurgery, what is very important is, does the patient have a patent foramen ovale? ठीक है, Arushi, what is the significance?
Ma'am, in case of craniotomy done in the sitting position, patients with patent foramen ovale will be at a risk of air embolism, which might go into the arterial circulation through the PFO.
So it is very, इसमें भी नहीं, even in normal patients, they are not always in sitting position, but they are always head up. ठीक है, and sinuses, venous sinuses are negative pressure spaces. They are always, they can be open, they can be exposed to the atmosphere, and there are chances of air embolism even in other surgeries, neurosurgeries. ठीक है, so knowing if the patient has a PFO or not is important for us. What is the incidence, Arushi, of PFO in adults? It can be up to 30%. ठीक है. So when you look in echoes, you must see if they have mentioned about this or not, especially if they are going to take the patient up. Depends on the location of the tumor. ठीक है? इसमें इतना आप नहीं रखेंगे pituitary में. In other tumors, you might make the patient more propped up. Okay?
Yes, ma'am.
ठीक है. और then you will see for left ventricular function and regional wall motion anomalies. ठीक है? आगे next investigation.
Ma'am, stress testing if required. Then we will need a baseline chest X-ray because we were suspecting it may have atelectatic changes and any pulmonary edema to rule that out, and any aspiration. And ma'am, CT and MRI would be ordered by the surgeon to see the size of the tumor and the location. And
CT में और क्या-क्या देखते हैं CT MRI में?
Ma'am, any metastasis of the tumor, any bone involvement, and involvement of the underlying structures.
And you can also find out the nature of the tumor. Vascularity भी पता चल जाती है. So you know how much blood loss can be anticipated. ठीक है? If you ask the surgeon, they will tell, or the radiologist, na, it's a vascular, highly vascular tumor or a non-vascular tumor, etc. Plus, how much structures is it engulfing? ठीक है? Is it compressing any nearby structure?
Yes.
ठीक है, इस केस में क्या important structure होता है in a pituitary tumor? Very important vessel which is lying next is the internal carotid artery.
Yes,
ठीक है, sometimes they can even encase the internal carotid artery, so it is very important anesthetic significance. ठीक है, because then these, if the surgeon is approaching, then there are chances of vascular injuries. Okay.
Yes, ma'am.
ठीक है, चलो. और what are the features of raised ICP in X-ray of the skull? किसी को पता है? वंदना, वर्षा?
मैम कॉपर पॉट साइन होता है.
Okay. क्या होता है
सिल्वर
copper
पॉट?
sign? सिल्वर
appearance,
appearance होती है, that is
beaten,
called
copper
silver
beaten
beaten
appearance.
हाँ, जो बोन होती है वो थिन्ड आउट हो जाती है बिकॉज ऑफ द रेज्ड आईसीटी, ठीक है। और उसमें क्या पता चलता है अंकुश, सीटी एमआरआई में हाउ डू यू चेक फॉर रेज्ड आईसीटी, व्हाट आर द फीचर्स, बिकॉज व्हेन यू सी द स्कैन्स यू हैव टू सी ऑल दिस, ठीक है।
मैम नहीं पता, आई एम नॉट श्योर।
क्यों
सीटी
मिडलाइन
एमआरआई के midline shift we can
midline
check
shift of
the
5 millimeters or more is significant. They can be
mass.
ventriculomegaly. The sulci and gyri will get obliterated. ये तो बड़े सिंपल
Right.
फीचर्स हैं, मैं
right,
रेट किताब से नहीं बता रही हूँ तुम्हें।
yes ma'am, yes ma'am.
ठीक है, ये तो this you can make out ना, ठीक है।
Okay.
This is important because when you're getting the patient and from when the patient has been diagnosed, there can be a rapid shift. ठीक है, there can be a rapid, these are all malignant or whatever tumors, they can grow suddenly, there can be sudden changes, ठीक है। So at all points of time you must look for all these changes, ठीक है। Conscious है तो क्या देखोगे, if there is deteriorating consciousness तो क्या क्या देखोगे, ठीक है। Any other investigation you would like to add, आरुषि, या हो गए सारे? I think we are done. Anybody?
मैम एक्सरे नेक लैटरल व्यू फॉर डिफिकल्ट एयरवे अगर हम सस्पेक्ट कर रहे हैं।
Okay, can be done.
Ma'am, the patients of acromegaly are more susceptible to diabetes mellitus, so we would also like to check for the blood sugars.
हाँ, of course. I think
And ma'am-
RPS, हाँ बताओ।
And ma'am, also they're more susceptible for sleep apnea, so we've not discussed about it.
क्या sleep apnea, so we will order?
Ma'am, so we've not discussed about sleep apnea की history, and like maybe we should like think about that also.
हाँ ठीक है, okay. History of sleep apnea, snoring and sleep apnea is important.
Yes.
Because of the hypertrophy of the laryngopharyngeal tissues.
Yes, ma'am.
ठीक है, good.
मैम इनडायरेक्ट लैरिंगोस्कोपी,
इनडायरेक्ट लैरिंगोस्कोपी तो नहीं करते हैं, किसने बोला?
मैम विधान
कर सकते हैं पर मैंने कभी ऐसे कराते हुए देखा नहीं है एक्चुअली। ऑप्टिक एग्जामिनेशन मतलब फंडोस्कोपी एंड आई एग्जामिनेशन इज समथिंग व्हिच इज टू बी डन, ठीक है। ओके भरनी, व्हाट आर द एनेस्थेटिक कंसर्न्स? भरनी सबसे ज्यादा पढ़ के आया आज, कहाँ है भरनी?
Ma'am,
anesthetic concerns for this case.
anesthetic concerns.
तेरा कैमरा पर।
Ma'am, camera on है ma'am.
हाँ बता।
Ma'am, anesthetic concern first the patient related as well as the surgery related, and in your patient related, patient will be having the large faces and everything, मतलब lower jaw, or with pharyngeal as well as laryngeal swell, मतलब soft tissue involvement. The intubation will be difficult.
Actually, just sorry to stop you at this point, but we classify the this thing as patient related, surgery related and disease related. ठीक है, डिजीज रिलेटेड, तो ये डिजीज रिलेटेड में आएंगी मुझे लगता है, ठीक है। दे आर नॉट पेशेंट रिलेटेड। पेशेंट रिलेटेड मींस इफ द पेशेंट इज ऑफ एनी एक्सट्रीम्स ऑफ एज, पीडियाट्रिक है, प्रेग्नेंट है, या एज रिलेटेड कुछ है, या कोई और कोमॉर्बिडिटी है उसको, ठीक है। दिस इज पर से द डिजीज रिलेटेड, तो तुम इसको डिजीज में कवर कर सकते हो, ठीक है। सो एनीवेज बताओ।
ओके एंड उसके बाद so these are all the मतलब these things related to the difficult in the laryngoscopy as well as the face mask ventilation.
तो ये फाइंडिंग्स आप बाद में बताओगे, पहले आप कंसर्न बताओगे फिर जस्टिफाई करोगे, ठीक है। दे कैन बी एंटिसिपेटेड difficulty in larynx ventilation and bag mask ventilation and laryngoscopy intubation because of this. ठीक है, concern is not the findings, concern is the concern. So first speak the concern, ठीक है। Okay, next concern.
Then
airway related concern. Second.
Yes, ma'am. Then anesthesia related concern because of the increased ICP.
Okay.
Regarding the drugs, whatever we are using, it should not rise the ICP level. So we have to select the induction agent as well as the muscle relaxant and everything according to that.
Okay. Then.
And surgery related, we have actually the approaches. whatever the approach is, whether it is a transpenoidal approach, yeah, frontal approach, yeah, it is a transcranial approach.
डिजीज रिलेटेड में कुछ और बोलना चाहोगे?
मैम
अभी तो तुमने पेशेंट ऑब्लिक डिजीज रिलेटेड जो भी बता रहे हो, तुम सर्जरी पे चले गए ना अभी?
यस मैम।
ठीक है, इट अफेक्ट्स वेरियस सिस्टम्स, है ना? अभी हमने लेफ्ट वेंट्रिकुलर स्ट्रेन की भी बात की।
हाँ, yes ma'am. Patient will be having other comorbidities also. Patient will be having other comorbidities also. So,
अंकुश क्या देख रहा है? नोट्स बना रहा है।
yes ma'am.
Comorbidities.
Ma'am, they will be associated with diabetes, hypertension, and left ventricular impaired function. So, other CAM.
Okay. So you have to take care of the hemodynamics because you have to maintain the cerebral perfusion pressure, coronary perfusion pressure, and otherwise also mean arterial pressure and other hemodynamic parameters should be maintained. Yeah. Or
yes, ma'am.
Anything else? Surgery related बताओ चलो. Any other ये चलो बताओ. Surgery related बताओ.
Ma'am, surgery related.
चलो surgery related Dr. Basav Kiran will tell us.
Good afternoon, ma'am.
हाँ, Basav Kiran.
Ma'am, it depends on the position required for the surgery and the risk of venous air embolism, ma'am. Whether it's a sphenoidal approach or a bifrontal craniotomy. Ma'am, the size of the tumor, the vascularity of the tumor, which decides the blood loss.
तो पहले कंसर्न बोलोगे, ठीक है? इट्स अ प्रोलॉन्ग्ड सर्जरी, ठीक है? रिस्क ऑफ ब्लड लॉस, रिस्क ऑफ हाइपोथर्मिया, ये तो ऐसे ही किसी में भी घुसा दिया करो। अगर प्रोलॉन्ग्ड सर्जरी है तो प्रोलॉन्ग्ड सर्जरी, हाइपोथर्मिया, ब्लड लॉस, ठीक है? ऑल दीज शुड बी ऑन योर टिप्स, ठीक है? फिर अगर कोई भी हेड एंड सर्जरी है, हेड, ब्रेन, ENT, upper part of the body, sharing of the head end with surgeons. Yes, this is very important. You have to say this, so you have to fix your circuits tightly, etc. करते हो ना?
Yes, ma'am.
तो ये सारा तो बोलना ही बोलना है, इसमें तो कुछ न्यूरो स्पेसिफिक कुछ भी नहीं है, ठीक है? एनी लॉन्ग सर्जरी ये सब आ जाएगा, एनी अपर पार्ट ऑफ द बॉडी सर्जरी तो फिर वो हेड एंड ऑफ द सर्जन शेयरिंग, ठीक है? दिस यू ऑल्सो हैव टू सेव दिस शेयरिंग ऑफ हेड एंड विद सर्जन इन एनी क्लेफ्ट लिप, क्लेफ्ट पैलेट, ठीक है? बिकॉज एयरवे इज नॉट इज टेकन अवे बाय द सर्जन्स, ठीक है? सो दीज थिंग्स यू हैव टू रिमेम्बर, ठीक है? और then you go to more specific concerns like venous air embolism or sorry,
surrounding structures, ma'am, like there is involvement is there.
ठीक है, ये main concerns are these only. Any other concern, Vandana, you want to add?
In case of concerns, even the size of the tube and the size of the mask must be large. Size of must be smaller, ma'am. Size of the mask must be bigger and fit.
This is preparation. See, question was concerns. तो जब उसने airway related concerns बताया तो उसके अंदर ये करोगे कि this is my concern, this is why the concern is there, and this is how I am going to tackle it.
Okay, ma'am. Okay.
है ना? This goes with the airway only. हाँ. Any other concern which is left out, Dwara?
I don't think so, ma'am.
हाँ, ठीक है. So this is all which you have to take care, ठीक है? So Basav Raj, is there? Basav Raj is there? Absent. Deepak, Deepti, हाँ बताओ.
Ma'am.
हाँ. How will you proceed with this case? What will be your pre-op orders?
Ma'am, in this patient, we'll be taking patient with the sedatives. We'll give pre-medications for the patient, and we'll give patient anti-Cyrolog and NPO.
कैसे orders क्या डालोगे? ऑर्डर्स क्या डालोगे एग्जाम में? ऐसे नहीं बोलना है हम ये कर सकते हैं, वी विल डू दिस नहीं, आई विल गिव दिस 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 टैबलेट दिस सो मच दिस। एंटी साइलोगॉग क्यों देना चाहते हो?
Ma'am, for secretion, ma'am, it's a state of hyper secretion state, so we can give
हाइपर सिक्रीशन स्टेट? एंटी साइलोगॉग क्यों देना चाहते हैं? Anybody else who wants to justify the use of anti-sialogol?
Ma'am,
They will
this
not give.
this is patient is acromegaly patient, and patient have an unanticipated difficult airway. So if we plan for a big fiber optic, then
This is
we
the
can
only
give
place
some.
where you will give if you are planning for fiber optic intubation. Otherwise, routinely anti-sialogogues are we giving?
No, ma'am.
दीप्ति कितने patients में दिया है? Which anti-sialogog you want to give to this patient?
No, ma'am, we will not give.
फिर क्या देंगे? क्या प्री ऑप ऑर्डर्स क्या होंगे? 1 2 3 4 5 तेरे पास रिव्यू पीएससी के लिए पेशेंट आया है, क्या ऑर्डर्स दोगे?
Ma'am, NPO, Nilpar Oler, will be decided that patient. If the tumor is highly vascular, we'll be anticipating the losses, then blood transfusion and BT.
अभी इस वक्त कहानी नहीं बोलनी है। Arrange blood, 2 units packed cells and FFPs according to the anticipated losses. बस ठीक है, आगे बोलो। Next.
Yes, ma'am, and patient is on any medication, so that will be continued as per the treatment of the patient, and there
Continue
will
all anti-epileptics and steroids and other medications which you have to specify. ठीक है?
Yes, ma'am.
ठीक है, what will happen if we don't continue anti-epileptics?
Ma'am, there will be chance of having seizures on OT table.
तो उससे क्या होगा? इंट्राऑपरेटिव सीजर है तुझे तो पता भी नहीं चलेगा, पेशेंट तो रिलैक्स्ड है, पैरालाइज्ड है, अंडर कर दिया है, बहुत अच्छी बात है।
Will worsen my pre-operative care.
Pre-operative?
If patient throw it,
suppose patient को इंट्राऑपरेटिव सीजर आता है तो what is the problem?
ma'am, there will be raised ICP.
Raised ICP, okay, और?
And ma'am, there will be
See, this will cause increase in the cerebral oxygen demand. CMRO2 will increase. ठीक है? हमेशा CMRO2 increased neuronal activity. Seizure means increased neuronal activity, increased oxygen requirement. So cerebral metabolic requirement of oxygen goes up. तो
Yes,
फिर
ma'am.
again oxygen supply balance, oxygen ये demand supply balance in the brain the balance is lost. So again there will be more chances of cerebral ischemia. ठीक है? So you have to prevent cerebral ischemia and you have to maintain cerebral oxygenation. These are the primary goals in any neurosurgery, है ना?
Yes, ma'am.
The primary goal is to maintain cerebral oxygenation. So hence continuing anti-epileptics is very, very, very important. ठीक है? And if it is a prolonged surgery and you need to repeat, you must repeat your anticonvulsant. Okay? आगे? So you have to specify, I will continue anticonvulsant, I will continue steroid and whatever other drugs the patient is on. ठीक है? जैसे she is on altroxin, so you will continue altroxin. ठीक है? और so you should have said altroxin also क्योंकि हम patient discuss कर रहे हैं. ठीक है?
Yes.
और
And ma'am, morning RBA should be done क्योंकि this is a case of glucose intolerance will be there.
Sugar and electrolytes.
Electrolytes, serum electrolyte can be taken.
ठीक है?
Yes, ma'am.
Okay. How will you prepare your OT, Deepti?
Ma'am, I will be taking care of airway related equipments and anesthetic drugs. In airway related equipments, we will be
बेटा जब भी बोलोगे ना after my routine OT check and routine preparation, I will also give special focused emphasis to this. ठीक है? रूटीन को कभी ये एक लाइन में आपको बोलना ही बोलना है. ठीक है? आगे बताओ. रूटीन चेक के भी तुम्हें अपने पॉइंट्स पता होने चाहिए. कोई किसी का मन करे तो पूछ सकता है क्या रूटीन चेक करोगे. So you should have a list of that also, which you don't have to speak unless somebody asks you. Okay? Which I can't discuss in this class. Chalo.
And ma'am, after having the routine check of the OT room, pre-warm OT, we'll be taking We'll be having the RBS of the patient and keep drugs prepared, anti-epileptic drugs to be there, and it can be given as per the surgeon demand. And if there is a requirement of mannitol also, we can keep.
नहीं, ये तो रखने ही होते हैं बेटा.
Yes, ma'am.
और
and emergency drugs.
Anesthesia workstation, anesthesia equipment से related something.
Ma'am, fiber optic can be prepared first.
Fiber optic सीधा. There is something called difficult intubation, difficult airway cart.
Ma'am, we'll plan.
कार्ट में क्या क्या होता है इसकी भी सब लोग लिस्ट बनाओगे. क्योंकि सब बोल देते हो फिर नहीं पता होता डिफिकल्ट एयरवे कार्ट में रखना क्या है. ना ही ओटी के अंदर आके कोई देखता है. क्या होगा डिफिकल्ट एयरवे कार्ट में दीप्ति?
Ma'am, in a difficult airway cart, we actually plan according to the drawers. In drawer A, we named as A, in which ET tubes can be kept. In B drawer, the next drawer, we can keep the supraglottic devices and airways. And in the C drawer, we'll be keeping face masks and other nasal prongs also. And at the top most place, we'll be keeping fiber optic and suction catheter, which is actually very long and cannot be kept in the drawers.
Okay, और video laryngoscopes रखना चाहोगे?
Yes, ma'am. We can put
special. We can have to check, है ना? Because patient का mouth opening और ये अभी ठीक है, तो if you're not anticipating, so plan A क्या है तुम्हारा और plan B क्या है, plan C क्या है?
Ma'am, in plan A, we'll be intubating the patient with ET tubes. If this will not succeed, then we'll go to plan B, in which
tubes से करेंगे दीप्ति. Intubation तो ET tube से ही होगा.
Ma'am, we can use direct laryngoscopy.
हाँ, direct laryngoscopy. Second will be video laryngoscopy and third is fiber optic. ठीक है? So in every case, your plan A, B, C should be ready and you have to prepare your OT accordingly. ठीक है?
Yes,
Swara?
Yes, ma'am.
Induction. How do you proceed once the patient enters the OT?
In a pre-checked, pre-warmed OT, we'll take the patient and since the patient is of acromegaly, we'll be confirming the weight of the patient and we'll be confirming the size of the OT table also accordingly. And after wheeling in the patient, we'll be checking, we'll be connecting. After checking the baseline vitals, after attaching the monitoring equipment like ECG, pulse oximetry, non-invasive blood pressure, then we'll be taking a cannula if at all the patient is not having any cannula. Then we'll be pre-oxygenating the patient with 100% oxygen for 3 minutes. Since this is a case of difficult airway, we'll be making sure the end-tidal oxygen is 90%. Then we'll be giving injection fentanyl. This is weight
Dwara. Actually, don't say this line because you are supposed to ensure ETO2 of more than 90% in all patients according to ASA guidelines.
Okay, ma'am.
Okay, so don't say that since this is. Don't say that. Just say we will ensure ETO2 is more than 90%. Okay?
Yes.
Because according to ASA guidelines, there can be unanticipated difficult airways. So ideally, all patients have to be pre-oxygenated. Okay? Which we routinely sometimes don't do, but don't say like this. Okay?
Okay.
Got my point? Just say that we will ensure adequate pre-oxygenation with a target of ETO2 more than 90%. Okay?
Yes, ma'am.
Okay.
And considering the weight of the patient is around 70, what is the weight of the patient?
What is the weight of the patient? Varsha will tell.
60 kgs.
Okay. Considering the weight of the patient is 60 kgs, we will be giving fentanyl 120 micrograms slow IV. Then we will be giving injection thiopentone 300 titrated according to the laws of eyelash reflex. Then we'll be checking the ventilation. Then we'll be checking whether we are able to ventilate or not. Ensuring adequate ventilation. If we are able to ventilate, then we will be giving muscle relaxant, injection vecuronium 6 mg IV, ma'am. In This patient, then
Okay.
we'll
Okay,
proceed.
hold. What are the precautions that you will take while performing bag mask ventilation in such a patient? Now you are going to do bag mask ventilation.
Yes, ma'am.
What precautions are you going to take? 1, 2, 3, 4 जितनी भी तुम्हें बतानी है बताओ, या कुछ भी कर सकते हो ventilation के time पे, or are there some points of concern?
In this patient, we have to maintain normocarbia all the time, so we should make sure that we are not
Normocarbia नहीं बोलेंगे, हम normocapnia बोलेंगे, okay? Because हम ABG नहीं करा रहे हैं, हम ET
yes.
कर रहे हैं, ठीक है?
Yes. So we'll not be hyperventilating the patient, and we'll be seeing according to the
normocapnia, और
apnea.
Second,
since this is
very important, mask should be of the right size. There should be no pressure on the eyes, no pressure on the soft tissues, because all this impedes the venous return. ठीक है, and this can cause raise in ICP. This can cause cerebral venous congestion. ठीक है, so mask holding should be gentle. ठीक है, without any compression of the soft tissues, eyes. The mask should not be covering the eyes. ठीक है.
Yes.
Gentle mask holding, gentle ventilation, maintain normocapnia, okay, and maintain adequate depth of anesthesia.
Yes.
Okay, because again, if the depth of anesthesia is not adequate and patient is fighting, then again your ICP and other things are going to increase. Okay, so all these points have to be taken care of. Okay, how will you maintain depth of anesthesia? How are you ventilating? Whenever you say I will do ventilation, you have to mention what gas mixture you are using.
Yes, ma'am. I'll be using 50-50%, 50:50 concentration of oxygen and nitrous.
50-50 नहीं बोलते बेटा, you should say FiO2.
50%.
0.5 points में बोलो, ठीक है?
Yes, ma'am. ठीक है. FiO2 50% of oxygen mixture and 50% of nitrous mixture, and I'll be taking isoflurane along with it, ma'am.
कितना?
Isoflurane at
Why do you choose isoflurane over other inhalational agents? Which is the best inhalational agent in such a case, and why? What are the benefits and harms of using inhalational agents?
Inhalational agents in a MAC range of less than 1, they'll be having the flow metabolism coupling will be maintained, ma'am. In a MAC concentration of more than 1 to 1.5, there will be flow metabolism uncoupling, ma'am. So
what is flow metabolism uncoupling?
There will be a proportional relationship between the cerebral blood flow and cerebral metabolic rate, ma'am.
Cerebral metabolic oxygen requirement.
Oxygen requirement, yes, ma'am.
CMRO2 and CBF are directly related.
Yes.
So what happens with inhalational agents? What happens with all the other anesthetic agents?
It is maintained in everything except
CMRO2 को क्या होता है? All anesthetic agents decrease CMRO2. ठीक है? Is there any agent which increases?
Except ketamine.
Except ketamine. So consequently, there should be a decline in CBF, है ना?
Yes, ma'am.
So that is called flow metabolism coupling. ठीक है?
Yes.
What happens with inhalational agents?
At a MAC greater than 1 to 1.5, there will be flow metabolism uncoupling, ma'am. The CMRO2 will be decreased, but the cerebral blood flow will be increased.
Why does the cerebral blood flow increase? आरुषि बोलो तो माइक ऑन करके बोलो.
Because of cerebral vasodilation.
They are all potent vasodilators. ठीक है? So that is why. Okay. This leads to something called flow metabolism uncoupling, and this leads to क्या term होती है? Luxury perfusion.
Luxury perfusion, yes.
But the perfusion is more than what is needed, so it is called. So you have to know these terms, है ना? ये बोल दोगे तो पता चल जाएगा कि पढ़ लिया. ठीक है? फिर then द्वारा so you can use inhalational agents, but you have to use them judiciously. At a MAC of preferably less than 1.7 to 1 MAC is good. Okay, Which is the inhalational agent of, which is the, what is the sequence of inhalational agents in decreasing order of rise of ICP or cerebral vasodilatation? Because more dilation means more rise of ICP. Which is the maximum, which has the maximum effect and which has the least?
Least effect is of isoflurane and sevoflurane. Both are almost similar.
Maximum is?
Nitrous.
Halothane? Inhalational,
Inhalation, yes, ma'am.
Fluorinated agents I am talking about. Halothane, enflurane, isoflurane, desflurane and sevoflurane. ठीक है?
Yes. Yes, ma'am.
HEIDS. ठीक है? चलो.
Then after confirming the check ventilation and giving the muscle relaxant.
Which is the muscle? Suppose you are saying this is a difficult airway, which will be your muscle relaxant of choice? You are saying, will you use choline? Will you not use choline? Pros and cons of using choline.
Choline.
Succinyl choline, sorry.
Yes, ma'am. Succinyl choline in a difficult whenever we are considering a difficult airway, we will be using choline, ma'am. But because it will be having short duration of action, but there is a risk of raised ICP in this case.
क्या करें फिर दोबारा?
Since we are not having rocuronium in our country, will prefer airway over.
नहीं तो रॉक्यूरोनियम आप दे दोगे? तुम्हें लग रहा है कि सपोज पेशेंट वेंटिलेट नहीं होगा, यू आर एंटिसिपेटिंग डिफिकल्ट वेंटिलेशन, पेशेंट इज हैविंग अ वेरी बिग जॉ, you will give rocuronium over choline?
Since we are not having Sugammadex in our country, we will be giving choline in our case, ma'am.
या तो वाइवा सुगामाडेक्स पे हो जाएगा दोबारा. ठीक है, so you should say कि ideally we can give any non-depolarizing muscle relaxant. Why choline is not to be given? Why should we avoid choline?
Choline has hemodynamic changes also, and there is a risk of raised ICP in this case.
Choline causes raise in ICP. ठीक है, so ideally you should prefer other non-depolarizing muscle relaxants. But if the patient is a difficult airway and because Sugammadex is not available, so airway will always take precedence. So you can use choline in the intubating doses, and the rise in ICP can always be offset with other drugs. Okay, you can give an additional dose of opioid or an additional dose of thiopentone and offset the ICP effect of choline. Okay, so don't be afraid of using choline if you think that the airway is difficult. Okay, if you think you'll be able to mask ventilate, you can use. That depends on the examination assessment of the patient. If ventilation seems to be difficult, anticipated difficulty in ventilation, then choline you can always say. It is not wrong to say choline. Okay, because rise in ICP can always be offset by other drugs, other IV drugs. Okay. And one also important concern of this during induction is that you have to maintain your mean arterial pressure. There should not be any hypotension, because fall in MAP will consequently lead to fall in cerebral perfusion. Okay, because during induction there induction. ठीक है, समझ में आ गया?
There is
Kanya, enumerate फटाफट 5-6 points for ventilation, induction, intubation, which I just said. कहाँ है? Kanya is there?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay, because it's showing bad network quality anyways. हाँ, Kanya?
हाँ, ma'am. Ma'am,
Camera
on, ma'am.
1, 2, 3, 4, 5. Just enlist the important points.
Ma'am, pre-oxygenate adequately. Use thiopentone sodium in titrated doses for induction. Ma'am, before induction we give a fentanyl opioid dose.
देना नहीं है concerns. See, maintain normocapnia, gentle mask ventilation, gentle mask holding. ठीक है, avoid fall and MAP. ठीक है, all these are the concerns while induction. ठीक है,
maintain a MAC of less than 1.
हाँ, okay, use appropriate drugs, choice of drugs. ठीक है, चलो. And what about intubation? Any specific concerns for intubation?
Ma'am, intubation, the laryngoscopy should be swift and gentle. Before intubation, we give drugs to offset the raise in the sympathetic response to intubation.
Very good. Very good. What should be the duration? Ideal duration?
Ma'am, less than 15 seconds of laryngoscopy.
Very good. Very good. Very good. Okay. Okay. Now how will you fix the tube in a case of TNTS? Now, if we suppose the surgeon is performing transnasal transsphenoidal surgery, anything else you want to do after intubation?
Ma'am, we'll do an oral packing, pharyngeal pack. We'll put it.
Okay, oropharyngeal pack has to be inserted and tube is ideally fixed on the left side because all the instruments and endoscopes, everything comes from the right side and interferes. Okay, so tube sometimes it is fixed on the left side. Okay. So then maintenance.
In maintenance, we will use oxygen, nitrous oxide and isoflurane, maintaining a MAC of less than 1.
Okay.
And we give neuromuscular blockers. We give adequate interval so that there is no movement of the patient at all. Ma'am,
what are the what all monitoring is to be used? Monitoring in this case?
Ma'am, ECG, pulse oximetry, capnography.
Oximetry is a non-invasive method for monitoring.
Ma'am, we can also.
Siri on हो गया?
हाँ मैम. Ma'am, non-invasive blood pressure monitoring. We can also neuromuscular monitoring.
Very good.
Temperature monitoring. And then we will keep a watch on the pressures, airway pressures.
Very good. Very good.
The urine output, the blood loss.
Very good. Invasive monitoring कुछ करेंगे? Non-invasive तो I think सब बता रही है. Any invasive monitoring you want to do?
Ma'am, we can do an invasive arterial BP monitoring and CVP monitoring as well. We can secure a CVC in case we are expecting to have to resuscitate the patient. We are anticipating a lot of blood loss.
TNTS is not usually associated with a lot of blood loss. So what is the indication of a CVP line in such a case? One is anticipated blood loss of inotropes is one thing, okay, for which a CVP might be needed. What else?
Ma'am, mannitol also should ideally be given through a CVC only.
Okay. Why?
Ma'am, because it is hyperosmolar.
कितनी होती है osmolarity?
1098 milliosmoles. 1098
per liter. ठीक है. Okay. Plus there can be a risk of air embolism always, ठीक है, neurosurgery. So you can aspirate air through the right heart catheter. ठीक है. What should be the position of this thing, CVP catheter?
It should be at the level of the tragus, so that it's at the level of the circle of Willis.
Depth of insertion, sorry.
Depth of insertion, it should be, the tip should lie at the junction of the superior vena cava and the right atrium. So if we're putting the CVC, we're taking a subclavian, right subclavian CVC, we can fix it at 14.
See, there are formulas according to height. So you can use those formulas, or there can be ECG electrodes which change the polarity as soon as you enter from the SVC to RA. So this is how you can guide your depth of insertion. What we are doing is generally, it's very ambiguous actually. We are not sure whether we are in the SVC or we are in the RA. Okay, so that junction, at that time, the positive and negative polarity becomes same. Okay, some times that electrode can be used if there is a transducer at the tip, or if it is not there, then formulas are there according to the height of the patient. So that should be used to determine the depth of insertion. Okay, or intraarterial line, invasive blood pressure monitoring. करेंगे?
pituitary transfemoral approach में
कर भी सकते हैं, नहीं भी कर सकते हैं, depends on the surgeon actually, surgical this thing competence. ठीक है. And one more very important role of CVP is sometimes the patient can have post-operative complications. So to chase the, you can see the osmolarity and all. Patient can have osmolar complications, NIDDM and all things like that. So for that sometimes CVP is required. ठीक है. Patient can even land in hypoglycemia. ठीक है. You might have to administer dextrose and all. So for that, CVP lines can be continued. Okay. Okay. So monitoring is over. What are your intraoperative goals, Kanya?
Ma'am, intraoperatively, we have to maintain normothermia, normocapnia, volemia, normotension. We have to provide a complete neuromuscular block. We have to maintain a MAC of less than 1. We have to
adequate depth of anesthesia. ठीक है?
Adequate. So we can also do in BIS monitoring for that.
BIS monitoring. Okay. और osmolarity and euglycemia. ठीक है?
Normoglycemia.
Osmolarity and euglycemia. ठीक है? So what is the IV fluid of choice?
Ma'am, IV fluids, we can, normal saline is the IV fluid of choice, but we can alternate it with Ringer's lactate.
Why?
Ma'am, because excessive infusion of normal saline may cause hyperchloremic acidosis.
Okay, very good.
We can alternate with Ringer's lactate.
Chalo, thank you. Hemlata?
Yes, ma'am.
So what is how will you diagnose venous air embolism in a case of neurosurgery?
Venous
diagnosis
air embolism.
And management of venous air embolism.
Venous air embolism can be diagnosed by sudden rise in end-tidal carbon dioxide with arrhythmias.
Sudden rise in EtCO2, Hemlata? Are you sure?
Yes, ma'am.
अच्छा, कैसे होता है? What is venous air embolism?
And basically, when the surgeon is operating, there is negative pressure through which some amount of air can be sucked into the epidural veins, and which can go to the systemic circulation. Other than that, when we are putting the CVC line, they can be if we are not.
Okay, CVC line की मैं बात नहीं बोल रही, न्यूरोसर्जरी की कर रही हूँ. ठीक है? So is it always manifesting?
And they can be.
How will you? What will determine if the patient, if the patient will manifest or not?
Ma'am, the volume of air.
Volume of air and most importantly, one more thing.
The site.
तो साइट से तो वॉल्यूम डिटरमिन होगा. अगर बड़ा साइनस खुला हुआ है तो वॉल्यूम ऑटोमेटिकली ज्यादा होगा. छोटा वेन होगा तो कम होगा, है ना? It is also the rate of entry of air into the circulation, because whatever little air is coming into the circulation, it is getting out from the pulmonary system. Okay, you are ventilating it out. So if it is coming slowly, little is coming, it is going out without causing much trouble. But if suddenly a gush is coming in a large volume, so volume and rate is very important, and this will be determined by the pressure difference. Okay? So suddenly if there is a negative pressure, if your volume is not good, patient is hypovolemic, then there can be sudden gush of air. Okay? Because anyways the patient is propped up and vessels are above the level of the heart, so there is some negative pressure over there. Okay? And these veins are not collapsible, they don't collapse, the sinuses. Okay? They are attached to the bone. Okay? So they will not collapse and stop the air entrainment. Okay? That is why the risk is very high. Okay? So what is the fatal dose of, what is the clinically significant dose of air? It is 3 to 5 ml per kg.
But through the central venous catheter, a volume of even 9 ml can cause.
Because it is so close, no? बट अभी हम सेंट्रल वीनस कैथेटराइजेशन की बात नहीं कर रहे हैं, ठीक है, अभी हम इधर स्कल से बात कर रहे हैं, ठीक है। सो हाउ विल यू डायग्नोज, what happens, what is the pathophysiology of venous air embolism? Sorry, I'm coughing.
It's okay. Ma'am, basically, it can cause a complete blockade in the coronary circulation.
से पहले कहाँ पे आती है और उससे क्या होता है? पहले तो वेन्स ब्रेन में थी, ब्रेन के वेसल्स में आई, एटमॉस्फेयर से वेन्स में घुसी, फिर वहां से कहाँ जाएगी?
राइट एट्रियम।
राइट एट्रियम में जाएगी तो क्या दिखेगा? टॉल पी वेव्स, ठीक है, पीक पी वेव्स, ठीक है, दीज आर ऑल क्लिनिकल फीचर्स ना, so you should correlate. Then RA से कहाँ जाएगी?
RA से it will go to the RV, then into the pulmonary
RV पे जाएगी and then it will cause obstruction of the RVOT, right ventricular outflow tract. तो उससे क्या होगा? उससे क्या होगा? एक तो left ventricular input will decrease, so cardiac output is going to decline, ठीक है, there is no forward flow is stopped, so cardiac output decreases, so there will be hypotension and tachycardia, ठीक है, and because cardiac output is decreasing, so coronary blood flow will also decrease, so that will lead to coronary myocardial ischemia, STT changes and arrhythmias, ठीक है. So this is the pathophysiology of venous air embolism, and because RVO2 is blocked, there is no pulmonary circulation, ठीक है, so there will be ventilation perfusion mismatch, ठीक है, VQ mismatch हो जाएगा ना, there will be ventilation but no perfusion, so that will lead to decrease in ETN2. सबसे पहले ETN2 जाता है नीचे, we don't have it, ठीक है, then you have sudden dip in ETCO2, it is not rise, blood आगे जाएगा ही नहीं तो फिर ETCO2 बढ़ेगा ही नहीं ना आगे, and PaCO2 will increase, so PaCO2 ETCO2 gap will increase, ठीक है, and there will be decreased PaO2 because ventilation gas exchange is not happening, ventilation perfusion mismatch हो गया, तो PaO2 will decrease, SpO2 will decrease, ठीक है, समझ में आ गया?
Yes ma'am.
And what will happen if there is a PFO, Hemlata?
Ma'am, then it will go from the right atrium, it will go to the left atrium, and then it will enter the systemic circulation.
Where? Cerebral circulation and coronary circulation, ठीक है, again this will further lead to coronary this thing ischemia, STT depression, arrhythmias and patient collapsing, ठीक है, patient does not collapse because ETCO2 falls, patient collapses because cardiac output falls, ठीक है, समझ में आ गया? ओके. Jayaram, diagnosis and treatment of, camera on please, दिख नहीं रहा मुझे.
ऑन है मैम. हाँ
ऑन है, चल बता फिर. अब ऑन हुआ है, आ गया, चलो.
डायग्नोसिस एंड ट्रीटमेंट ऑफ venous air embolism. Ma'am, diagnosis we can do with
we can नहीं, 1 2 3 4 5 जल्दी.
Ma'am,
don't be crisp in your answers, चलो.
Ma'am, first we can diagnose it clinically only. So monitor में we can see ETCO2. There will be decreasing in the ETCO2. If there is a
diagnostic modality for venous air embolism. VAE पे question भी आता है boss.
Ma'am, trans echocardial echography.
Very good. T, okay. T can diagnose even 0.02 ml per kg of air. ठीक है, चलो आगे बताओ.
precardial ultrasonography.
तुमने TCT बोल दिया, transcranial Doppler?
Transcranial Doppler.
Sorry, precordial Doppler. Sorry. तुम अल्ट्रासाउंड जो बोल रहे थे. न्यूरो सोच के ना ट्रांसक्रेनियल डॉपलर ही याद आता है. प्रीकॉर्डियल डॉपलर. हाँ देन प्रीकॉर्डियल डॉपलर में क्या मिलता है?
प्रीकॉर्डियल
मिल मर्मर भी मिल जाता है, उसमें भी मिल जाता है, ऑस्कल्टेशन पे भी मिलता है, पर उसमें भी मिल जाता है, मशीनरी रोर मर्मर, ठीक है?
Machine will murmur.
है ना? It is like the sound of a washing machine.
Yes, ma'am.
एयर होती है ना, हुश हुश ऐसे करके आवाज आती है फिर. ठीक है? और इसमें मिलती है 0.05 ml per kg एयर. सो दिस इज सेकंड मोस्ट सेंसिटिव. ठीक है? नेक्स्ट, EtCO2 ड्रॉप होने से पहले क्या ड्रॉप होता है?
Nitro.
EtN2.
Entitled nitrogen drop.
हाँ. और बाकी हमारे जो क्लिनिकल फीचर्स हैं. ठीक है? रेस्ट आर ऑल योर. हाँ.
SpO2 drop, then hypotension, tachycardia.
हाँ. Very good. So what will be the management?
Ma'am, management first. We should ask the surgeon to flood that area so that we can avoid further entrainment of air. Then, if a patient is, if we are giving nitrous oxide, we should stop the nitrous oxide and switch it to the 100% oxygen.
No, you just say 100% oxygen, even if you are not giving nitrous oxide. Okay? Because oxygenation has to be improved. Whether you are using air or nitrous oxide, FiO2 to be made 1. Then?
Yes, ma'am. Then position of the patient should be like head down position and head down position and right up. Yes, ma'am. Head down position and right up, ma'am. So that we can, ma'am. It will prevent the passage of the air bubbles further into the.
It will try to relieve the RVOT blockade, because air is lighter, so it will get lifted up. It will go to the apex of the ventricle. So our air is still there in the ventricle, but it is getting lifted off up from the RVOT. So RVOT obstruction is blocked, is relieved. So the blood flow starts. Okay? This is like a lock which occurs. Okay? That air is locking. It's creating a lock at the RVOT. So that gets relieved because the air goes up to the apex. Okay? So head down, right up tilt. What is the name of this position?
Durant.
Very Durant's position. Okay. Then?
इसके बाद ma'am, patient will be in like hemodynamical unstable. We should correct that also.
Correct that. Means supportive management with inotropes. And last is CPR. You should always be ready. If the patient has got VAE, be ready. You have to perform CPR.
Yes, ma'am.
Okay.
Yes, ma'am.
What else? Right heart में catheter डाला था हमने.
Ma'am, if there is a central CVC line, we can try to aspirate the air also.
ठीक है, मैंने किया हुआ है. चलो. Okay, so after VAE, okay. I want. Where is Jasmine? Is there? Jasmine? Yes, so how will you ensure adequate analgesia in this patient?
Ma'am, for induction, we have been giving 2 mics per kg fentanyl, ma'am. After that, we can give other analgesia. We can give incremental doses of fentanyl, ma'am, according to the duration of surgery, ma'am. Ma'am, towards the end of the surgery, we can give local infiltration. And then we can give paracetamol infusion also.
Can मत बोला करो. I will give. ये exam में can नहीं होता है.
Yes, ma'am.
ठीक है, तुमसे सर्जन पूछेगा तुम क्या करोगे. I will do this. ठीक है, ये can word अपनी डिक्शनरी में से हटा दो. चलो आगे.
Ma'am, other than that,
अगर suppose it is not a TNTS, it's an open craniotomy. Open craniotomy है तो क्या कुछ कर सकते हैं?
Ma'am, we can give morphine also during the surgery. Other than that,
morphine देने के क्या नुकसान है अब बता.
Respiratory depression.
अच्छा.
Other than that.
और क्या करता है morphine? Morphine क्यों नहीं पसंद न्यूरो एनेस्थीसिया में? What are the disadvantages of using morphine? It can be used, but I am asking what are the cons?
Ma'am, it can cause hemodynamic instability, ma'am.
MI के पेशेंट में तो इतना मॉर्फिन देते हैं हम। Jasmine?
Yes, ma'am.
It causes difficulty in pupillary assessment. ठीक है,
Yes,
it
ma'am.
causes prolonged
Neurology.
respiratory depression, rise in PaCO2. ठीक है, तेरा पेशेंट वैसे ही डिफिकल्ट एयरवे है, ठीक
Yes,
है,
ma'am. Yes, ma'am.
स्नोरिंग प्लस माइनस हो सकता है, जैसे डॉक्टर साक्षी ने मैं बताया था। तो देयर आर सो मेनी पॉइंट्स which are against the use of morphine, ठीक है।
Yes, ma'am.
ठीक है, assessment of pupils and assessment of consciousness becomes difficult, okay।
Yes, ma'am.
और क्या करोगे बच्चे? ओपन सर्जरी है, कैन यू गिव एनी ब्लॉक?
Scalp block kit can be given.
हाँ, क्या? What are the components of scalp block?
Ma'am, I don't know, ma'am.
कितने स्कैल्प ब्लॉक्स दिए? कितने न्यूरो सर्जरीज कराई? इतना कराते हो वहां पे, क्यों नहीं पढ़ के देते हो स्कैल्प ब्लॉक? You should all do. I have given peribulbar and retrobulbar also in my PG days. I used to stand in the IOT and eat their head of the aloka. I want to give peribulbar block. It is for you to snatch the opportunity and learn, ना? क्योंकि एक बार दे दोगे तो फिर कभी नहीं भूलोगे। किसने दिया है स्कैल्प ब्लॉक? So many neurosurgeries you perform in your duties. Who is going to tell me about scalp block? Rajeshwari is there? Rajeshwari, please enlighten us about scalp block. अच्छा, कौन बताएगा? वंदना और वर्षा में से कौन बताएगा? नेहा, तेरा नाम क्यों नहीं आ रहा इसमें? अच्छा ठीक है, आ गया। ओके, हाँ। ओहो, बहुत सारे लोग बचे।
In this we block 7 nerves, ma'am, from supraorbital, supratracheal.
कैसे ब्लॉक करना है, जल्दी बताओ, नहीं तो मैं बताऊंगी। एनीबडी हु वांट्स टू वॉलंटियर? तो अपना माइक ऑन करके बोलो।
Hello, ma'am.
Who is this?
Ma'am, Nisha.
हाँ, निशा बताओ। चलो बताओ, वेरी गुड।
Ma'am, for blocking the supratrochlear and supraorbital, ma'am, first we will in the midpoint of the pupil, 1 centimeter above the eyebrows. In that point, we can block the supraorbital nerve, ma'am, by infiltrating it with 3 to 4 ml of local
3 to 4
anesthetic.
ml बहुत बड़ा वॉल्यूम है। 1 ml is enough, निशा। 1 to 2 ml is enough for these nerves, ठीक है। You don't need 3 to 4 ml, ठीक है। Your supraorbital nerve,
yes, ma'am,
pupil and the infraorbital notch, they all lie in the same 3 line. Infraorbital block तो दिया होगा in cleft lips, है ना? So similarly, if you go up, you will find the supraorbital notch where Nisha is saying you give the supraorbital nerve block. Then supratrochlear.
Ma'am, in 1 centimeter, 1 to 0.5 centimeter medially, ma'am, at that point also, and fan, like a fan shape, we have to block the nerve.
So this is your supratrochlear, ठीक है। supratrochlear हो गया, supraorbital हो गया। फिर next कौन सा देंगे? Next you will give
auriculotemporal.
Auriculotemporal, just 1 centimeter in front of the tragus.
Feel for the pulsation of the artery, yes, ma'am. And then behind, posterior to that, we can give.
So at the level of the tragus you give it, ठीक है, and artery is generally in front of it, ठीक है। Then next nerve.
And the zygomaticotemporal, ma'am. Hello, ma'am.
हाँ, I can hear you.
Zygomaticotemporal, ma'am. From the lateral canthus, 1 to 2 centimeter posterior to that, feeling for the zygomatic bone, ma'am.
So you feel the zygomatic arch between the lateral canthus, means where the supraorbital ridge is finishing, and where you have given the auriculotemporal, ठीक है। Along this line, along the zygomatic arch, in the superficial and deep plane, you block the zygomaticotemporal nerve, ठीक है। Next, posterior auricular. Nisha?
Next,
posterior
yes,
auricular
ma'am. In mastoid को feel
हाँ
करना है मैम, and just posterior to the mastoid will
हाँ तो
we
behind the
infiltrate
mastoid,
with the
just
local
behind the
anesthetic.
mastoid at the level of the tragus. ठीक है? There you give block for the posterior auricular nerve. Next.
Next, the lesser occipital and the greater occipital, ma'am. We will see for the mastoid and the occipital protuberance, ma'am. And that line, we have to divide it into three parts. The first, the point where means from medial to the occipital protuberance, that at that point we can infiltrate with the local anesthetic for the greater occipital nerve, ma'am.
That is lesser
and
occipital.
then the two-third
Lesser occipital is medial. ठीक है? It is nearer to the midline. ठीक है? So along the superior nuchal line, this is the superior nuchal line which she is saying, between the mastoid process and the external occipital protuberance. So somewhere around the midpoint you give for the greater occipital nerve, and between the greater occipital nerve and the external occipital protuberance, just around 2 centimeters from the external occipital protuberance you give for the lesser occipital nerve. ये जाके पढ़ लेना सारे, ठीक है? So if you give a good scalp block, anesthesia requirements really go down. ठीक है? चलो, good attempt निशा. नेहा?
Yes, ma'am.
What are the advantages, or what are the spontaneous versus controlled ventilation, which is a better modality?
I mean, these patients, controlled ventilation will be a better modality.
Why?
Ma'am, because we can set the rate and prevent any hyperventilation.
ठीक है, you can maintain eucapnia, or
and
you can avoid coughing and bucking. ठीक है,
yes,
coughing
ma'am.
and bucking coughing
Yes,
and bucking can be avoided. It should be avoided at all times.
Yes,
ठीक है,
ma'am. Yes,
because
ma'am.
that leads to raise in ICP.
Yes, ma'am.
Or because the patient is not breathing spontaneously and negative pressure is not generated in thorax, so chance of VAE also decreases. ठीक है, venous air embolism का risk भी decrease होता है. ठीक है? Okay, so always controlled ventilation over spontaneous ventilation. ठीक है? So we have discussed analgesia, IV fluids, monitoring, complications. Block हो गया. हो गया, I think intraoperative concerns. Okay, Neha Dwivedi, can you tell us something about mannitol? Measures to control, drugs to control intracranial pressure intraoperatively. Drugs to lower the intracranial pressure.
To control intraoperative ICP, normally we use mannitol. Mannitol at the dose of 0.25 or 1 gram per kg.
Very good.
And secondly, we can give a diuretic. Diuretic we give is
mannitol के बारे में बताओ. What is the percentage? What is the onset of action, duration of action, mode of action?
We use mannitol, that is 20%. Yes, ma'am. 20% mannitol has been used. It is 350 ml of the bottle. It contains 20%. 60 gram of the mannitol it contains, and the dose is 0.25 to 1 gram per kg.
0.25
from the osmolality, 0.25 gram to 1 gram per kg, and the osmolality of the bottle is 1098 milliosmol per liter.
Very
that
good.
is the osmolality, ma'am. And osmotic diuresis it causes, ma'am. With the help of that, it reduces the ICP.
Any other beneficial effects of using mannitol? It has got certain rheological advantages. It decreases the blood viscosity, increases the cerebral perfusion, blood flow properties are improved.
Yes, ma'am.
It has an anti-sludge effect also. It inhibits apoptosis. It has a cerebral neuroprotective effect also. Okay, so these are the other benefits of using mannitol as a ICP lowering agent. Okay, what are
Yes, ma'am.
the contraindications?
For the mannitol, ma'am, if the blood pressure systolic BP is less than 90, we have to avoid using mannitol.
Okay.
And if the patient is already diabetic
incipient heart failure, incipient renal
incipient heart failure and renal failure, in
precipitated.
that case
Okay.
also we have to avoid. Yes, ma'am.
This is very important. And what is the disadvantage?
It causes diuresis, ma'am. A lot of the fluid is
This electrolytemia हो सकता है, and it can cause rebound edema. If the blood, suppose this is a tumor, blood-brain barrier is not maintained, so it will cross into the brain tissue and it will cause edema inside the brain only. ठीक है? So you have to be careful. ठीक है? Which are the drugs which help in maintaining the integrity of blood-brain barrier? Steroids. ठीक है? That is why steroids
Yes,
are
ma'am.
given in cytotoxic edema. Cytotoxic, ये जो cytotoxic edema कहते हैं ना इसको, because of tumors. So
Yes,
that is
ma'am.
why steroids are always given. ठीक है?
Yes, ma'am.
Okay. Next drug. What about hypertonic saline?
Hypertonic saline, it also osmolarity is 1040. The same thing it does, ma'am. Actually, it
Osmolarity
decreases
depends
the.
on what concentration you are using. ठीक है?
Yes, ma'am.
Okay, 3%
3%.
की कितनी होती है? नेहा बताओ.
Osmolarity is 1024, ma'am, of
नहीं
3%.
3% की कितनी होती है बेटा? 513 मिलीकुलेंट्स पर लीटर. चेक करना. आई थिंक इट इज 513. ठीक है? 0.9% की कितनी होती है?
मैम 309 मिलियोस.
हाँ ठीक है, 309 होती है ना. 3% की चेक करना. लेट मी नो इफ आई एम इनकरेक्ट. ठीक है, ग्रुप पे बता देना जो भी है. बट एज फार एज आई रिमेम्बर इट इज 513 मिलीकुलेंट्स पर लीटर.
यस मैम.
ठीक है, कितने ml की बॉटल होती है हाइपरटोनिक सलाइन की?
मैम 100 ml की बॉटल है. 3% NaCl.
ठीक है, so you have to be careful about not causing hypernatremia in these patients. So you have to watch for signs of hyper ECG changes and other toxic signs of toxicity of sodium. So treatment has to be titrated with the sodium levels. ठीक है, initially you can give a dose of up to 3 ml per kg slowly. ठीक है. अच्छा, मैनिटोल का ये नहीं बताया. नेहा कहाँ गई? ऑनसेट ऑफ एक्शन कितनी देर में होता है? पीक इफेक्ट कब आता है और ड्यूरेशन ऑफ एक्शन? वंदना बताओ. दिस इज वेरी इंपॉर्टेंट. वंदना बताओ.
Mannitol onset of action is 10 to 20 minutes, ma'am, and its peak effects is 30 to 60 minutes, and the duration of action is 4 to 6 hours, ma'am.
What is the relevance of knowing this?
Ma'am,
peak effect is coming in 30 to 60 minutes. So that is why you don't have to give mannitol when the brain is open. You have to give mannitol around craniotomy or just after incision, so that when the surgeon is reaching the dura or at that time, the effect of mannitol is there and brain is not going to herniate out.
Okay.
Okay? So you have to time your mannitol properly. Okay?
Okay.
Okay. What is the advantage, Neha, of then what about Lasix? What is the dose of Lasix and what is the advantage of Lasix over mannitol? Lasix भी तो देते हैं ना? What is Lasix?
Ma'am, it is loop diuretic. Lasix we
कौन सा loop diuretic?
Thiazide, ma'am.
चलो पल्लवी बताएगी अब. पल्लवी is there? Pallavi Paruthi is not there. Pooja. कोई नहीं है.
Yes, ma'am. Pooja.
हाँ, Lasix.
Ma'am, will give loop diuretics. Ma'am, the problem with diuretics is patient can have hypotension if patient was already on diuretics preoperatively, and intraoperatively will not be able to give patient hemodynamically is not stable, and it can also cause hypokalemia.
डोज क्या होती है लैसिक्स की फॉर डिक्रीजिंग आईसीपी?
Ma'am, will give 20 mg.
ओके, 20 mg दे देंगे.
Ma'am, we can give it in divided doses also. Initially, we'll give 10 and then we'll see the response and then we'll do
Okay. Vijayvani, you want to add something? Vijayvani is there?
Yes, ma'am.
हाँ, बताओ.
But regarding LASIK,
क्या डोज होती है, क्या वो होता है, ड्यूरेशन ऑफ एक्शन होता है? लैसिक्स तो हर
ma'am, I don't remember the dose of the duration of furosemide, ma'am, but it is a loop diuretic, and the mechanism of action is it inhibits the sodium potassium 2 chloride transport and causes diuresis.
So dose is 0.1 to 1 mg per kg you can give. ठीक है? Lasix, the beauty of the name is it lasts for 6 hours. So duration of action is 6 hours. Do you know that is why it is called Lasix? ठीक है, check कर लेना. I think duration of action is 6 hours. ठीक है? And what is the advantage?
It is given as a BD 3 days dose only, ma'am.
हाँ, तो ड्यूरेशन ऑफ एक्शन इज ऑलमोस्ट 6 hours. यू कैन गिव इट अप टू QID. लिवर सिरोसिस वगैरह में देखना क्या डोजेस देते हैं. 6 hourly QID देते हैं. ठीक है, get back to me. Then, what is the advantage of Lasix? The problem with mannitol, which was there, that if the blood-brain barrier is not intact, and it will go to the other brain tissue and it will cause cerebral edema, that does not happen. Okay, it will not go to the cerebral tissue because it is not an osmotic diuretic. Okay, so that problem will not occur. It is a loop diuretic. It is acting at the renal level. Okay, not an osmotic diuretic.
One more thing. Yes, ma'am. Chronic mannitol administration can even cause osmotic demyelination syndrome, ma'am. That is not seen with loop diuretics, ma'am.
Okay. This has a ceiling effect also. Mannitol does not remain active after some days because osmolarity, once it gets risen, then it will stop acting. Okay, you are causing hyperosmolarity. Once you have raised it, it will not act, na?
Yes,
ma'am. Okay. Sudhir is there? Sudhir कौन है? Sudhir?
यस मैम.
हाँ जी सुधीर, अब बताओ एक्सट्यूबेशन कब कैसे करेंगे?
We'll make sure that the patient is fully awake. We will make sure that the patient is fully awake, and we will first remove the throat pack.
ये पेशेंट को आपको एक्सट्यूबेट करना है, तो आप क्या क्या ध्यान रखोगे?
When fully awake, and we will remove the throat pack.
Awake से पहले बेटा, will you extubate or not? Decision of extubation will depend on what factors? आपने बोला prolonged surgery भी हो गई थोड़ी सी, है ना? So what are the factors which will...
And patient is hemodynamically stable.
Very good. Hemodynamically stable, one. Second.
And if
temperature is normal, okay, hypothermia should not be there. Or
when we will see the patient is having the all reflexes and spontaneous.
वो तो प्रोसीजर बता रहे हो और क्या क्राइटेरिया है कि आप एक्सट्यूबेट करोगे या पोस्ट ऑफ वेंटिलेशन के लिए भेजोगे?
heavy blood loss. If there will be blood loss.
Okay. Okay. हाँ और पेशेंट ने न्यूरो सर्जरी करी है सर्जन ने, तो उससे बात करना चाहोगे हीमोस्टेसिस एडिक्वेट है कि नहीं, है ना? ब्रेन टेंस तो नहीं है, एडीमा है कि नहीं, ठीक है? सो यू हैव टू टेक इनटू अकाउंट ग्लोबल सिस्टमिक फैक्टर्स एज वेल एज local factors, ठीक है? तो systemic factors are in your control, local factors are in the control of the surgeon. You should have a closed communication with the surgeon, ठीक है? After ensuring patient is hemodynamically stable, normovolemic, normothermic, ठीक है? And intracranially there are no contraindications, hemostasis is good, brain is not tight, then one will proceed for on table extubation, ठीक है? Okay, Rohan, what are the advantages of an on table extubation versus controlled ventilation?
On table extubation allows us to have since we are in OT prepared with all the airway equipments, if post extubation any complication related to airway arises, we can immediately monitor and perform adequate intervention.
Fine.
And post if we are there is early in case of neurosurgery, we can have early neurological assessment.
ठीक है, a focused early neurological assessment. It is called a targeted neurological examination. Then
yes, ma'am.
And the sympathetic responses to a retained tube are not there, ठीक है? Because if you are retaining the tube, then you have to ensure that there are no responses.
Patient have tube tolerance, yes, ma'am.
ठीक है, so you have to ensure adequate sedation. So all that tube related responses and hemodynamic consequences are offset, ठीक है? So if possible, one should always go in for an on table extubation. Rohan, can you explain how will reversal and extubation be done?
Ma'am, in this surgery, we have been performing the neuromuscular monitoring. So, in order to give the extubation dose after ensuring all these criteria, like patient has hemodynamic stability.
Okay, okay, that they are satisfied. Sir.
And if then we need to check the TOF percentage, ma'am. If it is TOF count is 4 and percentage is more than 90%, then we can. Then we'll give the neuromuscular reversal agent. We'll give injection glycopyrrolate at the dose of 10 microgram per kg and neostigmine at the dose of 50 micrograms per kg. Slow IV.
Okay.
Then, ma'am, after this, we'll wait and try to elicit the proper signs of extubation when the tube can be taken out. For example, there has to be sustained hand grip for 5 seconds.
After ensuring adequate neuromuscular recovery, फिर?
Ma'am, and
that's enough?
No, ma'am, we have to, even while performing extubation, we have to prevent the sympathetic response, ma'am.
Very good.
Because that can also lead to increased ICP. So we can give IV lignocaine, ma'am, at a dose of 1 mg per kg.
What else?
Ma'am, we can give esmolol also 250 micrograms, 250 to 500 micrograms per kg.
Or? Other drugs? Labetalol can be used, diltiazem can be used. ठीक है? All these drugs you can use to ensure that
while extubation there is no pressure response.
No pressure response. And one more thing which you have to maintain while extubation during the reversal process, very important, is eucapnia. We tend to go towards hypercapnia.
Yes, ma'am.
Okay, we have a tendency to let the patient accumulate CO2 and breathe, so that should not be done. Okay, it should be a slow process, maintaining the vitals, maintaining the hemodynamic parameters as well as the carbon dioxide levels. You should not allow hypercapnia. Okay, no hypo. Just like induction, you should not allow hyperventilation. Here, you should not allow hypoventilation. Okay, so you should either assist ventilation if required, unless the patient is maintaining eucapnia. Okay, so that is very important, because again the ICP is going to rise.
Be altered, yes.
And that will lead to a secondary rise in mean arterial pressure, which you will be treating with drugs instead of controlling the CO2. Okay?
Yes,
so that has to be taken care of. And then once the patient is fully awake,
ma'am, then while performing the suction and giving positive pressure, will deflate the endotracheal tube cuff, and the tube will be taken out while suctioning and providing positive pressure.
ठीक है, okay, so you do tracheal extubation. ठीक है, अच्छा. Okay, now you tell me, if the patient is now having adequate respiratory efforts, but the patient is not getting up, what will you do?
After extubation, ma'am, or before?
Before extubation, if the patient is not conscious and obeying commands, you cannot extubate.
Definitely, ma'am.
है ना? तो patient breathe कर रहा है, आपने reversal दे दिया है, patient is breathing, generating good tidal volume, everything is okay, but the patient is not awake.
If the patient is not awake, ma'am, then I will not extubate the patient.
First of all, trachea is extubated, patient is not extubated. ठीक है? Okay, first, ठीक है, so trachea will not be extubated. Okay, but what will you do? First of all, you will have to rule out the anesthetic causes. Is there a residual anesthetic cause? तुमने क्योंकि जब बोला तो तुमने अपना अभी तक इनहेलेशनल एजेंट तो बंद ही नहीं किया, रोहन. है ना? इनहेलेशनल एजेंट कब बंद करते हैं? तुमने बहुत बढ़िया से बताया कि 0.9 ये आएगा और मैं अपना रिवर्सल एजेंट आई विल बी गिविंग. At what point ideally you should be switching off the inhalational agent?
Ma'am, right after the surgical stimulus has stopped.
No. It is after the respiration comes back, because a paralyzed patient should never be aware. ठीक है? Paralyzed patient should never be aware. ठीक है? So you have to ensure depth unless your monitor is showing 0.9 and you have given reversal and respiratory efforts have come. Now patient is having his own respiration, then you should switch off the ideal I am saying. जो हम करते हैं वो हम बहुत ही depending on कि अब 3 बज गया, अब मुझे next case लगाना है, वो वाला नहीं है. ठीक है? So once all this is there and the patient is having its own efforts, you should induce paralysis only when the patient is deep, and you should take him out of this depth only once he is off paralysis.
Paralysis is gone, yes.
Paralysis should always be under a proper depth of anesthesia is what I am saying, because that leads to a lot of traumatic awareness.
Yes,
awareness can be there. Awareness without paralysis is okay, but awareness with paralysis has a lot of psychological consequences. Okay? So ideally, then you will turn off your inhalational agent. In the end, you will rule out, if the patient is not waking up, you have to rule out all anesthetic causes first. ठीक है? तुम surgeon को नहीं blame करोगे. First, all anesthetic causes have to be ruled out. Gases have been washed. Max have reduced. Your end tidal expiratory levels, if there you have the agent monitoring, you can see expiratory gases are 0. Last timing of opioid, last timing of relaxant, everything is well in place. And the patient is not hypothermic and other metabolic derangements are not there. Then you can think that it could be a non-anesthetic cause. Okay. So after all this has been ruled out, then you give half an hour to the patient. And if still the patient is not waking up, you must do a check CT scan to find out an organic cause. Okay.
Yes, ma'am.
And you proceed with elective ventilation. ठीक है? अंजुषा समझ में आ गया?
Yes, ma'am.
Samriti, what can be the causes patient is not waking up, non-anesthetic causes? Samriti?
Hello. Yes, ma'am.
Samriti?
Ma'am,
beta.
it could
Waking up?
ma'am, it could be
Non-anesthetic
due
cause.
to any surgical cause, or it could be due to dyslipidemia
I am
or
asking you the non-anesthetic causes.
ma'am, then it could be a consequence of the surgery.
क्या हो सकता है बेटा?
Uh,
There could be a hemorrhage. तुमने ध्यान नहीं दिया, bleed हो गया, BP बढ़ गया, अंदर bleed हो गया, ठीक है? So that is why
Yes.
maintaining hemodynamics is very important. ठीक है? Otherwise also there can be inadequate hemostasis and there can be a tumor hematoma can be there, okay? Or there can be edema because of excessive tissue handling, ठीक है?
retractors, which
हाँ,
they
ठीक है?
use for
और दे कैन बी अ न्यूमोकेफलस, जैसे ये हमारा फ्रंटल साइड का सर्जरी अगर इधर से ओपन किया है या नहीं भी किया है, एनीवेज न्यूमोकेफलस कैन बी देयर, ठीक है? So all these are factors. Otherwise, it can be this thing. Other neurological factors can be there. ठीक है? But all these are correctable factors. Hematoma है तो patient can be taken back. Hematoma can be removed. ठीक है? Edema है तो it has to be treated medically, है ना? Or you can put a this EVD or any other shunt can be placed or whatever. ठीक है? And what will you do if there is a pneumocephalus?
Ma'am, then we'll have to intubate the patient and maintain.
Extubation तो किया ही नहीं ना समृद्धि, पेशेंट उठा नहीं, एक्सटुबेशन तो किया नहीं, न्यूमोकेफलस आ गया है.
Ma'am, then we'll take
is
the patient on
pneumocephalus?
100. We'll take the patient on 100% oxygen. FiO2 will make.
What is pneumocephalus?
Ma'am, it is air inside the cranial cavity.
Okay. So basically, once the surgeon is operating, so air gets accumulated. Ideally, they wash the field with saline and try to eject the air. ठीक है? And then they keep the bone flap and everything. But still, sometimes, especially in deep brain surgeries, olfactory area surgeries, and frontal surgery, sometimes, especially in these surgeries, air can be retained. Other surgeries also, there can be a pneumocephalus. But these frontal surgeries are the surgeries where it is more common. Okay. So, what is the treatment? It is elective ventilation. It gets resolved. This air comes out of the ventilatory system. Okay. Nothing to be done. Patient will awaken after some time. Okay.
Okay.
फिर post-op monitoring. Satish. post-op management. Satish. Physically present, mentally absent. Satish is not there.
No, sorry. No, ma'am, my mic was muted, ma'am. Sorry. Yes, ma'am. Ma'am, we should apply the standard monitor.
तेरा शिमला.
No, ma'am, I said effective, ma'am.
हाँ, बताओ.
Yes, ma'am. Ma'am, routine like we should monitor the ECG, cardiac activity with ECG, ma'am. Then SpO2 monitoring should be done and BP monitoring, ma'am. Then we should assess the GCs also, ma'am, of the patient, whether it's maintaining or not, whether he's improving or whether like if he's disoriented after extubation. So we should be keeping eye on his GCs also, ma'am. Then we should supplement with him, supplement him with the
oxygen. So say in one line, vigilant monitoring of 1, 2, 3, 4, 5, 6. ठीक है? Okay. Then
yes, ma'am. Then we should like yes, ma'am. Telling something. Then we should. Yes, ma'am.
Oxygen.
Yes, ma'am. We should supplement with him oxygen, ma'am, through antimos. Then we should assess for pain also, whether he's having pain, if he's complaining of any pain. So we should manage that also, ma'am, with like if opioid dose is over.
We can. I will manage it.
Yes, ma'am. I will manage, ma'am. With if dose is like due, I can give the dose of NSAIDs, ma'am. For pain management. Then
be specific. No, I will give PCM 1 gram IV. Whatever you say, something specific.
Yes.
ठीक है, whenever you answer, please don't give ambiguous answers. Please give specific answers. ठीक है?
Yes, ma'am.
तुमने initially block भी दिया था, अगर open था, है ना?
Yes, ma'am.
Anyway,
Yes, ma'am.
PCM can be continued.
Yes,
PCM diclofenac combination can be continued, है ना?
Yes, ma'am.
You can give 6 hourly doses, or you can give patient controlled analgesia. Use these terms, no?
Yes, ma'am.
Using an infusion pump, okay? Or monitoring of vitals, or
Then IV fluids, ma'am. I will maintain the IV fluids. Euvolemia should be maintained, ma'am, with NS. So like maintenance dose, ma'am, 60 kg means 100 ml per hour. I will maintain, ma'am.
Okay.
Then if it's a CVP line, I will do X-ray, ma'am. Then post-op CT surgeons will do, ma'am, for the patient. Then.
ठीक है. Vandana, any other post-op points?
Ma'am, we'll monitor for electrolytes, ma'am. Especially in pituitary case, there is a known complications like diabetes insipidus, otherwise syndrome of inappropriate ADH.
Exactly. ठीक है, specific to pituitary tumors. Okay.
Yes, ma'am. So.
Okay, so you can read the differences. कोई पूछेगा नहीं इन दोनों के बीच में, because it is more of a endocrine this thing. इतना डिटेल में नहीं पूछेंगे. I think we have covered everything. I'll just check. And if anybody wants to ask any question, has any doubt, can ask. Any doubt?
Ma'am, in case IV fluids, they tell we must not give RL because it is hyposmolar when compared to the plasma. That is.
No. You have to maintain a balance between NS, this, everything, because giving only NS also has its own complications. So now they say alternating 1 liter of NS with 1 liter of finger slash.
Can give na ma'am instead of the
yeah.
plasma light, ma'am. Plasma light.
Plasma light can be given. Plasma light can be given.
Yes, ma'am. Thank you.
Any other doubt? Anyone? Yeah,
ma'am.
Hello, ma'am.
This is Rohan.
Rohan.
Ma'am, in endocrinology review, if we take off pituitary cases, they write that we have to give injection hydrocortisone.
Just a minute. Just please hold. Chandan, lock नहीं करना. Lock मत करना. Department lock तो नहीं दिया. हाँ. Okay.
Ma'am, endocrinology review, if we do of these patients, they often mention injection hydrocortisone 100 mg IV at induction specifically.
वो तो हम वैसे भी स्टेरॉइड दे रहे हैं ना.
Any specific thing for induction? Why they are mentioning it?
Actually, it is not mandatory. Intraop भी कई बार कहते हैं, because sometimes they say कि when they remove this steroid level decreases and the patient can have resistant hypotension. Otherwise, it is not there too much in the recommendations. I had gone through this. ठीक है?
Okay, ma'am. Okay.
They had a patient of hypotension resistant, which was most probably due to hypovolemia. So just to be sure, they have started giving steroids now, but it is not really recommended. ठीक है? I have gone through the literature regarding this. ठीक है? May be given, may not be given. This is just to supplement the steroid levels because you're doing surgery over there. To prevent inadvertent depletion of corticosteroids from the body. ठीक है?
Hello.
Yes.
Ma'am, Naresh, ma'am. Ma'am, I wanted to know about the use of nitrous in this case because someone said that nitrogen, they will give nitrous. So
nitrous oxide can be given. See, although it is known to have effects cerebral vasodilatory and raise ICP and increased risk of VAE, but meta-analysis and most of the studies, they don't find a significantly increased risk when nitrous is not used. So it can be given, it is on the discretion of the anesthesiologist. Okay.
Okay, ma'am. Okay, ma'am.
But it should be avoided if there is a venous, if you have a complication has occurred, then it can be avoided after that. Okay? Otherwise, it is not known to decrease the incidence of complications according to literature. Any other doubt? Varsha? ठीक है, okay?
Yes, ma'am.
चलो ठीक है. Then I think we can call it a day. ठीक है?
Thank you, ma'am.
Okay, thank you.
Thank you, ma'am.
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 Thank you, ma'am.